today we're joined by Dr. Andrew Jowett. So Jowie, as we'll call him, I think, for the webinar. We've got a fairly relaxed approach here. Seems very un-Australian to call you Andrew. We are very pleased to be joined by Jowie, who is the clinical director at Olympic Park Sports Medicine in Melbourne. So for those of you who are not aware of Olympic Park, it's probably, I would say, the biggest and most impressive sports medicine clinic in Australia, certainly in Melbourne. And I guess Andrew probably, or Jowie, will tell us a little bit more about this in a minute, but he's a sport and exercise medicine physician. And the main reason we've got him on is because he has been living in a kind of COVID-19 environment for arguably, well, longer than we have. And we thought it might be an interesting idea to share some of his experiences practicing in that environment over the past, I guess, 12 months or so. So thanks very much for joining us, Jowie.
Pleasure.
Yeah,
Thanks.
so apparently hairdressers open in Melbourne tomorrow.
Yeah.
So Jowie normally has a shaved head like me. He's gone the full Rolf Harris. So it's kind of a bit Rolf Harris. It's not good anyway. And we're also joined tonight by Dan, who just wanted to come and be part of something. He had nothing else to do. Done his click and collect, and yeah, I don't know. He just had nothing else on, so he might sort of share some insights. So Jowie, I guess maybe a good place to start might be just to kind of, if you could give us a little bit of an overview about your clinic and kind of what it's like. I guess some of the challenges about your clinic. And maybe we'll just go from there. Just before you do start, remember there is the Q&A button down the bottom. And if you do want to ask questions, it would be really great to get some audience participation and any questions you might have. And the Q&A button is better than the chat button. So feel free to bang through the questions, and I'll try and pose those to Andrew and possibly to Dan too, if he's looking a little bit sad and bored down there. So we'll see how we go. So can you tell us a little bit about your clinic, Jowie?
Yeah, thanks, Mark. We're a private multidisciplinary sports medicine centre. We're about 30 odd years old, one of the earliest founded in Australia, in Melbourne. We're a primary teaching practice for the College of Sports Physicians. We have about 70 practitioners who operate under our roof. And this is part of our roof behind me. That's Amy Park, which is our multi-purpose rectangular stadium where the Rebels, Melbourne Storm, Melbourne Victory play. As I said, we have about 70 practitioners, about 20 physiotherapists. We have massage therapy, diet, psych, podiatry, some exercise physiologists, and as I said, sports physicians and registrars, and a few specialists that come in. So that's worth remembering when you're talking about a COVID situation, because I think one of our strengths, or that enabled us to keep operating, was having doctors on site, and maybe a slightly more open attitude towards providing an ongoing health service. We are based in Melbourne, which is the capital city of Victoria. We have about population, I think, in Melbourne's around 3.5 or 4 million people. But we see patients from all over the state, which can be, I went to a place called Mildura on the weekend, which is about 6 hours drive from Melbourne. So we have a lot of, and that's really important because we'll talk a bit about telehealth in the future and how that's impacted us.
Cool. And I guess we have an interesting operating environment in that we're all predominantly funded by one government-based insurer. So can you perhaps it's probably worth just talking about the structure of the health system in Melbourne and your practicing environment? Yeah,
I might just, what have I done here? No, I've done something wrong. It doesn't matter. I was going to share a screen, but it's not. Oh, hang on. Here we go. Are we okay there?
Yeah, all good.
Look, the disclaimer I wanted to make was that I'm a sports physician. I'm not an ID physician. I'm not an epidemiologist. I'm not a microbiologist or even an intensivist, but this is my practical experience rather than any sort of legitimate professional experience. Just this, why I wanted to show it is this shows our health system. It's a messy and mixed health system, I think. If you look at the graph, the mid-green sectors on the outside is the federal government, the light green is the state government, and then the dark grey is the private funding, so patients pay. So we have a mixed public and private system. Essentially, the federal government pays for outpatient medical health services, and the state government pays for the public hospitals. And there's a private health system with private hospitals as well. In terms of allied health support, there's some federal money funding that goes to allied health. There's some funding that comes from private health insurance. There's some funding that comes from work-related insurance and other insurers like that. So that's sort of how our health system essentially tries to work.
And so I guess if you think about, the last 12 months practicing in kind of an uncertain environment, one of the things that we have had in our New Zealand practicing environment is that there were some fairly fixed rules about who could practice and who couldn't. So, for example, physiotherapists were not allowed to practice. What was the kind of Melbourne take on that?
Yeah, so the COVID brought out a lot of weaknesses in a lot of systems, and one I see is this sort of federal and state system divide. And what we found out that most of the power really lies with the state governments, and they make the rules and they set the border rules, not the international border rules, but effectively in some ways they do. But they certainly set the state border rules, and they set the state rules regarding who can work. And so we had our state government, Victoria had a significant outbreak. I guess I'll just show you this sort of graph I pulled up today. This is from the Johns Hopkins data. But you can see it goes right back to the start of the pandemic last year when we had a little blip. That was our first lockdown. And then a major lockdown last winter. We've actually had 6 lockdowns. We've had the most lockdowns in any country or any state in the world. We're world champions of something at least. And we're currently as of midnight tonight, we come out of our sixth lockdown. This one's been going for about 80 days, I think. Ironically, we're coming out of lockdown with the highest cases we've ever had. And I guess that'll be something we can discuss. During the lockdowns, we've had a work from home rule. And so the rule is if you can work from home, you must work from home. Our general practitioners have been encouraged to continue operating, but again, where possible, provide services via telehealth. And our specialist practice, such as us and allied health, have been under a rule where you're meant to only see patients that are urgent, patients that are going to require treatment, and if they don't get that treatment, their condition may deteriorate. So there was no blanket use, and that included physiotherapists and the like. The one group that struggled was our massage therapists. They basically ruled that out. And I think that was just lazy. I think they struggled to discriminate between, professional massage therapists in clinics like ours and massage therapists in shopping centres, offering neck rubs and the like. And so essentially they said, no massage therapy. Physios, allied health can operate in those situations where it's urgent. Now, in the end, that was left up to the individuals to determine. And in some ways, it's hard to decide if they're urgent without actually seeing the patient. And so there was a fair bit of laxity on how that rule was interpreted. But I guess the relevant thing is we haven't seen any cases that have been proven to be transmitted, you know, in that sort of close contact. So we've had physio, we've had medical services, we've had, you know, even podiatry and the like. But as of midnight tonight, ironically, the government hasn't actually formally released the rules, but supposedly as of midnight tonight, we're allowed to go back to routine care. We sort of had a philosophy that as a medical group, certainly, in that it was our role to take some of the pressure off the hospitals and off the emergency departments. And I don't know what you guys saw during lockdown, but I saw an enormous amount of radiculopathy. And, you know, that's pretty significant for people and often significant enough for someone to need pain relief and going to hospital. And I guess it's all this sitting in front of screens and the like that we saw that.
So Joey, did you kind of have a rule of thumb? Was there a kind of high level discussion about what acuity was? Did you think about trying to do some sort of telehealth screen before you saw the patient to try and determine acuity? What sort of strategies did you use there?
We basically put that almost onto the patient or the referring practitioner. Mm-hmm. So our medical specialists see patients on referral from general practitioners. And so we, in some ways, shifted that onus onto general practitioners. And to be fair, it was, in some ways, the general practitioners were telling us that, well, they're allowed to operate. They're meant to see people. What do they do with the patients if they want to refer them? So there was sort of a practical component to that. We did discuss early on, gosh, way back when, you know, in lockdown number 2, maybe in lockdown number 1, whether we should put some imposition on that. The problem is the government was slow to come to the telehealth option. So we went to a privately funded telehealth model initially because we saw we'd need it. The government weren't funding it initially. And so, if you're trying to convince a patient to pay for the time on telehealth versus come and see you when they get some funding back from the government, it's a pretty easy decision for the patient.
Yeah. So given that you are having these patients coming in through the clinic, and I know that you've had some COVID positive patients through the clinic, what have you actually done kind of within the practice or within the consult to try and reduce the spread of illness?
Yeah, well, we've had, as far as we know, we've had 2 COVID positive patients come through the clinic, identified through testing outside. But nevertheless, we followed all the rules and the strategies and tried to come up with ours. And I know certainly, Mark, I saw you published very early on your strategies at Access, and I think that was really informative. We didn't quite go to some of the lengths you did, and our government rules sort of were different, obviously. So certainly the pre-screening protocol is important. The government had that sort of symptom screening. We set up an automated SMS system that went to patients on the day of their consultation, where they had to declare any symptoms and the like. Early on, that also included declaring any travel and the like. And then, so you're pre-screening. We pre-screened all our staff and practitioners every session. We have an indoor mask mandate essentially since that major lockdown last winter. Surgical masks only. Eyewear available. we didn't go to the length of some practitioners went to the lengths of scrubs. There's partly, I guess, one other difference is that we don't employ our practitioners. They essentially, employ us to provide their services. And so there's a certain amount of freedom they have to practice as they should. We certainly put in quite heavy cleaning strategies early in the piece when it seemed that sort of surface contact might be an issue. Although I think our thinking on that's changed quite a lot. What else?
So I understand from the font of all knowledge, Adam Castricum, that you've had to employ someone to do a deep clean.
So
how'd that
so I'm
go
going to
down
blame
for
Adam for having the patient who was actually a hospital administrator who worked at a public hospital where they'd had a significant sort of internal COVID outbreak. He went to Perth on a conference and came back and tripped on a gutter and ruptured his Achilles tendon, and hopped into the clinic to see Adam with a ruptured Achilles tendon. When he went, Adam chose to manage him conservatively and manage him surgically. And when he went to hospital, they just instituted this pre-surgical COVID screening. And the COVID test came positive. And so all of a sudden they start tracing things back. Where have you been? And so that's when Adam had to go into quarantine for 14 days, and we had to do a deep clean at the clinic, and that cost us about $6,000, and we had to shut for a day, and obviously that cost us income and the like as well. We've had to do that on one other occasion. The government policy has changed on that now. I was reading some data out of Brazil that maybe is counteracting the sort of significance of transmission via sort of surfaces, which has been a lot of the international narrative, really, that we need to address the aerosol first and foremost.
So I mean, that's quite an interesting point about how things are changing so rapidly. You need a deep clean today, but you might not need a deep clean tomorrow. And just remind me later on, I've got some data to show that might be quite useful just around the impact of different patient scenarios, different infectivity, and different types of PPE use. But that document, the first thing that it talks about is that document is going to be updated in 2 weeks' time. So the changing landscape is something that's quite incredible. So we've had quite a good question come through from Rose. Are you required to have screening COVID tests? Is that something that in your practice that you guys have thought about? Are you doing any sort of surveillance for staff?
We've definitely thought about that. So I think obviously, I mean, the two big, you talked about changes. The two big changes were the strain. So obviously that large wave at the end relates to the Delta variant, which obviously has its characteristics of transmissibility. The other change is vaccinations, and that's been the heavy focus of public health. We were a bit late to the game. There's sort of blame games around that. Our government didn't lock in contracts enough, but we didn't have much COVID really compared to the rest of the world. And I can understand it, why there wasn't a rush. And the states in Australia that are slowest to take up vaccination don't have any COVID at the moment. So why would they? And the states that are the biggest uptake are the ones that have had big outbreaks recently, like New South Wales and Victoria. So the focus is about vaccination, and we certainly have. So the state government's mandated full vaccination for healthcare workers, including all our workers. So, and we have to keep a record of that. And in fact, if we don't keep records and we don't have full vaccination, then there's $100,000 fine for that. So So full vaccination of healthcare staff is essential. The screening is something we've talked about, and it comes into this interesting discussion about at the moment we're starting to move into this sort of segregated. Oh no, that's a bad word. Segregated, differential sort of economy with the vaccinated and the unvaccinated. And as of tonight, if you're fully vaccinated, you can go to a limited number of restaurants and hotels. If you're unvaccinated, you can't go in. You're locked out. Now, that's been mandated by the government, but it hasn't been mandated. And I'm not sure you could mandate that in healthcare. Certainly something. But there have been a number of physio practices who've dabbled with that, and that's one has taken the decision to do testing using the rapid antigen testing, which is only actually just available. Problem is, they come at a cost of between $10 and $20. They take about 15 minutes to do, and they need to be done by a registered healthcare practitioner. And so that's the challenge for us at the clinic, and not really something we're looking at undertaking. Other clinics have said you have to have a negative PCR test in the 48 hours before. That again is a challenge, because an asymptomatic PCR test is not meant to be funded by the government, and they're about $150 if you go and arrange it. They're the sort of things the airlines are expecting for overseas travel, which I can understand, but maybe not for a medical review appointment.
So there are a couple of questions here around one you've kind of answered about treating vaccinated clients differently in terms of access, and then the second one is it worthwhile checking for temperature? And perhaps just before you get into those, I have some information today from the College of General Practitioners about their recommendations around unvaccinated, unmasked patients. So we could perhaps park that and come back. I've also got some personal experience about what the private hospitals are doing in Auckland. So they require a screening COVID test, saliva test, before admission into the hospital. And you have to go to 3 external sites away from the hospital. You have to have that done days in advance. It is very logistically challenging at the moment within the Auckland environment. So, you know, like you, I think, Joey, undoubtedly that's going to change over time. But it's not going to change quickly, I don't think. The other thing is that the legality in New Zealand around excluding people based on vaccination status is untested. And if you're interested in looking at more, I attended an interesting webinar through Icehouse. Is it Icehouse, Dan? Business School, Business Dudes? Can't remember. Yeah, Icehouse, which is available online if you want to go watch it. It's from Thursday. And so there's some interesting things based on your behavior as an employee. What are you, an employer rather? What can you expect of your employees? So if you're a practice owner and you're kind of grappling with this type of decision, it's quite an interesting one to go and watch. And I think that's been uploaded now. So the question that I kind of hijacked there was around temperature testing and whether you're doing anything different for vaccinated patients at your clinic.
So I don't know about you, Marco. Your answer to the temperature testing is pretty much ours. We dispatched with that really early on. We knew that plenty of COVID patients present without a temperature, and there's the asymptomatic transmission. And it wasn't. They were doing temperature tests at the Epworth Hospital, private hospital near us, on every day, on everyone who went through the door, and didn't pick up one positive recording. Now, that's not a proper study. They didn't do PCR on them all, but that's an enormous number of people. And so we dispatched with that pretty early on. In professional sporting teams, they were doing that. I think that was more to be seen to be done. I again am unaware of anyone being excluded because of a positive temperature test. Look, the elite sporting environment is actually interesting to look at. We're talking about professional sport, or at the moment I call it commercial sport, and they've just. I'm sure your experience in Tokyo, or with the New Zealand team, was pretty much similar to Australia, where they had a fantastic experience and great control. But they were doing daily rapid antigen saliva tests on every person, staff member, athlete, every morning, and that's the chief medical officers of the commercial sports in Australia have come out with a protocol, depending on the incidence of COVID in the regional community where you come from, on how that screening's going. And so we've been discussing that, and I was actually discussing that today. So in Melbourne, we'd be a red sort of level 3 area. And so they would be expecting, and they're planning to test every athlete and staff member daily with the saliva tests, and then twice weekly PCR testing. So it's a whole level above what we're doing in the community, but they sort of seem to think it's required to keep their sort of sport operational. So yeah, sorry, that was just a by comment about the testing. I think, yeah, the temperature testing we dispatched with that, I think it's not useful. What was the other part of the question? It was
around whether you personally have made any decisions about unvaccinated clients.
Yeah. So so our state government mandated it for certain workers. It actually wasn't just healthcare workers. They mandated it for construction workers because there were some large outbreaks on large construction sites. And I don't know, you probably saw on the news the marches we had through the city by any troublemaker who went down to the local reject store and bought a fluoro vest and wanted to march and create havoc. There was certainly provoked a response, but the real construction workers jumped on board. When there's a government mandate, it's easy. But when it's a personal decision, it's very difficult. As a doctor, I think I have an obligation to treat whoever. Some of my practitioners have decided otherwise. I agree with you, the legalities around it are untested. We're the same situation in Australia. It's discrimination as far as I can see it. If you're not discriminating, you need to offer a viable option for those, and that may be something like testing, pre-screening testing and the like. There are also some people you can't vaccinate, so under 12s don't have approved vaccinations available at the moment, and so you're going to, if you take only vaccinated patients, you're going to exclude that population. You may exclude a very small number who are sort of really have a vaccine contraindication. Oh, I've just dropped out.
I did that to you.
Oh, cool.
Yeah. Sorry about that.
Screen share.
So look, I thought I might quickly share some stuff that's hot off the press from our from the College of General Practitioners. So I think in New Zealand, they're the group that are probably the most exposed to COVID-19. So I think, and they're probably the group that are the most relevant to the audience here. So they're working out in primary care, they're in the environment, they're away from a hospital, they don't have the same support from the DHB that we might have. And so I think that they're going to bear the brunt of whatever happens in New Zealand over the next little bit. So
and we've looked at those too, Mark. But they are relevant, but they're also high risk, I think. We have to admit, compared to our practice. Yeah,
I mean, I think the key strategy for our practice, and probably for everybody on the call, is just not having sick people in the practice and minimizing exposure. So if you can do things to stop the patient being physically in the clinic, then obviously that's helping. Then if you can do things to minimize exposure, as I'll show you these tables where minimizing time in your room, thinking about the use of PPE, and then just making sure that people that are not sick don't come in, then you've reduced or eliminated a lot of that risk, whether patients are vaccinated or not. So I'm just going to quickly share my screen for a second. Just, I know this is your show, but I thought that they were quite useful given it's a New Zealand landscape. So if I fire that up, now, can you see that? Is that looking all right? Yeah, so just, I guess, first of all, just a shout out for the College of General Practitioners. The second one, this document here is from a new one, a relatively new one out from the Ministry of Health. And as I said to you, that the key, or one of the interesting things there, if you look at the top of the document, it talks about how it's effective from the 16th of October and will be reviewed again on the 29th of October. So it really does kind of illustrate the changing landscape. And then the other piece that I think is interesting to look at is this table down the bottom. So I don't like slides that have so many words on them because I get confused, but it talks about how the risk, or the what makes you a close contact, or what how they judge your individual risk as a clinician and whether you need to be isolated is based on a number of different details. So some of it is where the exposure happens. So a great example is if it's in a hospital, it's going to be much higher risk than outside of a hospital. If it's outside, the risk is lower. Then there's some stuff related to the infectivity of the patient. Then there's the amount of distance, there's your behaviors yourself, including PPE. And then there's some things around the actual physical environment you're in, room size, whether you've got good ventilation, those sorts of things. So it's not simple as there's a COVID patient in the practice or there isn't. So if you think about us as clinicians being in a room, spending time with the patient, you're going to be much higher risk than the people out in the front desk in a waiting room. So yes, the exposure in the waiting room might, there will be exposure, but you will not be as close to that patient for as long as you will be with a clinician. So when you're talking to your reception staff, that probably offers a level of comfort. Then the next thing in this document, I'm just going to skip ahead in the document to the last part, which is what happens to you if you're, whether how you're classified as being a casual contact, a casual plus contact, close contact, or close plus contact. And up here it has vaccination status. So if you're fully vaccinated versus being partially or unvaccinated, that makes a tangible difference. So I just kind of want you to think about casual contact. And if you're fully vaccinated, you don't have to stand down. You continue to come to work. You're only required to monitor for symptoms. And if you become symptomatic, you must test. So there is essentially, that is what I would call common sense behavior, business as usual, keep going, as opposed to if you become a close plus contact, you must isolate for 10 days. So you are not going to be at work. You will not be able to keep doing your normal things. And say if you're a close contact and you're unvaccinated, you still must stand down. And if you're a casual plus contact, you must stand down. So for you and your practicing, there is a tangible benefit to being vaccinated. And then if we'll come back to this document in a minute, but this is how risk is currently being classified. So this talks to this idea about low risk exposure being in a shared indoor space greater than 1.5 meters. So that doesn't mean a consultation room. That probably is more reception for less than 30 minutes, as opposed to over here, which is probably more like a standard follow-up consultation, face-to-face contact within 1.5 meters and less than 15 minutes. And then over here, prolonged face-to-face contact for more than 15 minutes. So this is probably, this table here is low risk is reception. This one here is a follow-up consultation for a lot of people, 15 minutes. And this one here is probably a new patient consultation. And then if you come down here, you then look at what it means to you if you're fully vaccinated or partially vaccinated. So if we have a look at this one here, which is the partial or fully vaccinated for the new patient consultation. If you do not wear PPE and your staff and your patient does not wear PPE, you are going to be considered a close or close plus contact, which is not good. That means you're likely going to stand down from work. And then if you have a look down here, if you wear a mask, it doesn't change your risk at all. But if you wear a mask and the contact wears a mask, then that means that you are a casual plus contact. If you wear an N95 mask, that means you're a casual contact. And so if you wear an N95 mask and you wear eye protection, that means that there is no risk considered to you. So when you're choosing your behaviors and you're thinking about PPE, I think it's sensible to think about what is the impact on you if you don't care about the community, which some people don't. Just think personally, selfishly, what can I do to mean that I'm able to keep coming to work? And if you wear an N95 mask or a P2, they're the same thing, essentially, and you wear some eye protection goggles, they are European, North American, Chinese, then you are not going to be asked not to come to work. And so if you just look again at the criteria, the difference between casual contact and close plus contact is quite significant to your working life. So I'll post this document to the Facebook page after we've finished here, so you can have a bit of a look at it. The other thing that just came out today from the College of General Practitioners was some information about what to do if you personally don't want to see someone who's not wearing a mask, or if you personally are not wanting to see someone who is unvaccinated. And for us, it's a little bit different to the general practitioners, where there is more that duty of care. But the reality is we are not required to see anyone. There is no obligation for us to see patients, but there is an obligation to provide an alternative. And so offering the examples down the bottom, like offering a telehealth consultation to triage the patient or finding somewhere else for them to be seen, is a really useful idea. And in private practice, you know that the hospital system and general practice are running a red and green zone. So they have clinicians that are actively seeing patients and are resourced to see patients wearing full PPE, including P2, N95 type masks. And the same thing for patients who refuse to wear a mask. You can essentially decline to see them if they do not want to wear a mask. So there are patients out there that will refuse to be vaccinated. We've had them through the clinic already. We've had interesting interactions and emails with 15 to 20 bullet points. And I think a key strategy, certainly from my point of view, is to engage with them and ask whether they've been vaccinated as part of a standard medical history. I think that's less threatening for them. So you're asking about their medication use, you're asking about past medical history. It's a nice time to ask about vaccination status. And it's not a big thing. It's kind of more integrated into the consultation. But then just not getting in a big argument, I guess, is the key thing for our staff. So you can encourage, you can question, you can offer a minimal encourager, like you might do with a smoking patient who's pre-contemplative. They haven't quite decided whether they want to quit smoking or not. There's no point beating the horse or getting into a big argument with them. So again, I'll pop this document up on the Facebook page. And there is another one around risk stratification. So if you are a clinician who is pregnant, or if you are a clinician that has an underlying medical condition, it talks about when you should consider not coming to work. So there are three quite good documents that are all very current, and I think all have some direct relevance to you and your practice at the moment. So I have kind of hijacked that a little bit, but I thought that they were quite interesting documents that were kind of quite relevant to our conversation.
That's really good, Mark. We've been working from a similar document, had similar discussions, and I guess what we were in that stage, and we had the discussions. And you're right, there's this choice about just whether you want to keep practicing and keep operating, and the best way to do that is to manage your exposure, and you've talked about the importance of vaccination in that, but that's really all about how you will be assessed by the case contact tracers. Yeah, I agree. The masks and the eyewear are considered very highly as part of that. I would challenge a physiotherapist to wear an N95 mask for a full sort of session, being very physical about it, day after day, week after week. It would, basically rub all the skin off your face, I would imagine. But those P2 masks are much more tolerable. So some of our practitioners have chosen to wear them. They are expensive. If you're going to comply with how they properly should be used for safety, you have to change them every 4 hours. But I don't think the case contact tracers check that sort of thing. So if you want to comply, then I'd get a P2 mask and wear some eyewear.
Yeah, look, I think also you need to get them fit tested as well. It is a very
the P2 you
process.
don't. The P2 you don't. The N95 you do. That's right. It takes about 45 minutes. It costs hundreds of dollars. Yeah, it's a challenge. But the P2 might be worth looking into.
The other thing for me that was quite striking on that table was the influence of having both the clinician and the patient wearing a mask. And so if you have a mandate in your practice, which we do, that everybody wears a mask all the time, it becomes a much easier sell, and there's not really much fuss about it. Whereas if I contrast that with some friends who work in general practice, where some patients wear a mask and some don't, it becomes really kind of adversarial and people get quite pissed off about it. So that's one of the things that I think has been a kind of quite good thing for our clinic, is that we've just made a decision that everyone will wear a mask all the time. And then it just seems to mean that the conversation is not quite the same.
And we ask them to change their masks. Often they've got, cloth masks of unknown quality, and we provide a surgical mask on the desk for them to wear. I had an interesting discussion with a patient refusing to wear a mask the other day because he had a mask exemption because of his asthma. But he'd also decided that he wasn't going to have a vaccination. And so I thought, oh, well, you're front of the queue for an ICU bed. So that's, don't you understand that you've got a lung disease and there's this virus that kills people with their lungs?
How'd that conversation go for you?
Yeah, short and and moved on without review.
Yeah.
And that's the point, is that managing a practice, you have to be aware of your front desk staff who are going to be exposed to this sort of, when you make these decisions, it's all very well, but they often have to bear the brunt of it, any of the mandates you make. And so you need to have strategies to deal with that, or support that, or circumvent any pressure at the front desk. But the one point I was going to make is that if you're truly concerned about safety rather than just ticking the boxes for contact tracing, is that I'd do something about ventilation. Open your windows. Think about the HEPA air filtration systems. I think that's the game changer, and that will really make a significant difference. There's a good reason why, it's hardly transmitted outside. Can you take your practice outside? Can you do an exercise session with a patient outside rather than, in the room with you, or something like that? Use ventilation. I reckon that's a game changer. And I guess the other thing I wanted to make about your table is, that's all very well when you're having a few hundred cases a day. Today we had, as I said before, we had over 2,000 cases a day. Our contact tracers can't keep up. They're not listing tier one, what we call tier one exposure sites with close contacts anymore. And so things are going to change when you start to learn to live with it. And that'll be really interesting to see how that is. We've certainly they've recognised that they couldn't keep furloughing all these hospital staff because of exposures, because they just wouldn't have enough staff. And if people were going, so they've actually cut some, and that tables like you showed have helped sort of allow people to stay at work, and especially as they're mandated to be fully vaccinated. But we're now down to sort of 7-day quarantines with testing and the like. So that's for reasons like that.
I mean, I think that's a really important point, that if people out there haven't clocked onto that this is about to change significantly. And so the conversations that we have, I'm on a group called the Council of Medical Colleges, where all the medical colleges discuss issues relative to medicine, but there is no doubt that we're going to stop thinking about stuff like isolation and probably even things like vaccination rates, and maybe to some extent we'll become a lot more blasé about it. We'll be much more concerned about bigger picture things. So if you will have someone with COVID in your clinic within the next year for sure, and it's just about how you mitigate that risk and make sure that you're safe. So thinking about things that are important right now is important, but having a kind of longer term view, I think, is really important. Thinking about what your practice might look like in a year. We're still going to be wearing masks for sure in a year. So if you're not, you will get COVID. I think so.
I mean, we're gonna hit 90% vaccinated in the next few weeks. But under a month.
Mm-hmm.
And if you look at the UK, I mean, there was a brief dalliance with vaccination passports and the like. But if you've got 90% vaccination coverage, then is there any point in mandating vaccinations and checking vaccination status anyway? So you might. Well, at the moment, we're wrestling with, should you see vaccinated or not, unvaccinated or not? But if nearly everyone is, does it really matter? Is it worth the headache?
Yeah, it's a very cheery thought. So yeah, we're time's marching on. I was wondering whether anyone out there has any more questions that they might want to ask. Joey, so without getting into too much detail, as a business owner, you mentioned the challenges supporting the front desk. Are there any sort of other business challenges that you'd like to speak to?
I guess what's really immediate. Hey,
managed to pay your rent? Looks like quite a flash stadium.
We had good government support in the first sort of year. So there was good governmental support last year, but not much this year. And so, yeah, in some ways you have to keep operating for that point of view. What's been, I mean, obviously it's hit us much harder than you guys. But what we're seeing in the population is people moving to regional areas because they've been working from home and they realize they don't have to work in the city and catch that train in and out of the city. And maybe they can live in the country and have a different lifestyle. Maybe you can work from home more, and so all that infrastructure in the city is going to change. We've noticed they're talking about this great resignation sort of that's going to happen. All these people resigning from their jobs because they've had time to think about what they're doing. Am I in the right occupation? What am I going to do with what's important in my life? Things like that. And so I've actually got 2 staff I've got to replace, now, and that environment in a really dynamic environment is a real challenge when people are reconsidering, what's important, and they don't know what the future is going to be like. There's so much uncertainty, and so from a business perspective, that's a sort of real consideration that you need to think about how you can retain the staff you've got, and if they have been working from home, what's been good about them working from home. Who does well at home? Who does better in a group environment? Absolutely, and we've also learned how fantastic telehealth is, and we just hope we can maintain that going forward. And I think we've got enough patient drive that they would just pay for it because of its convenience. But that's been our big positive is telehealth. Yeah,
I think we probably all found that, although it's hard to think about that right now because I'm so sick of
it. Yeah.
There's a question here about visors and goggles. So are you wearing visors? You've got your goggles on now, do you? Or
they're just seeing goggles.
Yeah.
I wear those little plastic shields on a plastic sort of glass thing. again, I think a lot of that comes from the droplet spread sort of ethos. I think the aerosol transmission is where it's at, and I'm not sure.
So
I'm not sure how well they contribute, but if you want to tick the box, you've got to have something more than these, something at least. And the shields at least have a foam thing that stops stuff coming down here. It doesn't stop it coming up here though. And when you inhale, you're going to get some flow that way. But if you're going to wear, if you're an ICU, by all means, you wear face seal, whatever, and a sealed mask and everything. But in the clinic, tick the box, have something rather than nothing. But yeah, think about the aerosol spread.
Yeah. So I mean that's sort of borne out in that table that I showed before around, that there is they consider it lower risk if you are mitigating the aerosol spread by wearing goggles or a shield. But probably that is not routine, certainly out in general practice or primary care, unless the patients are in the red zone and they have respiratory symptoms. There are some quite cool goggles out there. So I got deep down a goggle rabbit hole earlier this week, trying to look for the coolest goggles that I could find. But got to look on Amazon for some.
Do they come prescription though?
Yeah, you can get prescription ones as well.
They're good.
But I suspect that may be something that becomes a bit more interesting as the case numbers increase. So, if you're dealing with 2,000 cases a day or 3,000 cases a day, then maybe your appetite for wearing goggles at work increases. There's a thing around what PPE do we use at our clinic. And at the moment, across the board, we've got surgical masks for the patient and for the provider. And then it's up to the provider at the moment whether they want to wear a P2 or an N95. But we are just going through the process of getting people fit tested for N95s. We're looking at doing that because I think mostly because around that risk profile and the cost associated with buying N95s essentially is mitigated or offset by having people stay at work and not have to go home sick, or not having to go home and self-isolate. So that's what we're currently doing: surgical mask for the patient and for the clinician. Dan, do you have anything to add? You've sort of been sitting there, just I don't know what you've been doing.
No, I only had one pearl, which was one from Chris Hanna about the best ointment for mask rash, which is bepanthen. So just thinking of, Joey was talking about physiotherapists wearing masks all day and rubbing your face off. And I went through the whole first lockdown with surgical masks and getting fogged up goggles, and was taping the surgical mask to my face. Then I ripped my face off. So a good fitting mask, but bepanthen, Bepanthen is a great ointment if you get mask rash.
That good comment. You use it on any other rashes or?
Well, I was thinking it could be useful for teenagers.
Very good. We're not wearing gowns, Susie. So we have gone for scrubs, Joey. So most everyone, great for everything according to bepanthen. But the great thing about the scrubs is come to work, wear the scrubs and then dump them in the washing machine and they stay at work. So it's been I have really liked it. It's been, along with telehealth, one of the revelations of the pandemic is wearing scrubs at work and not having to wear a suit, and showing up to work and leaving in clean clothes, which has been quite cool. So we're not wearing gowns. Again, I think for those of us out there in treating non-respiratory symptoms, it's about risk mitigation. And so we are seeing low risk patients. We do not need to hold ourselves to the same standard, and unless we want to, that the ICU or the red stream primary care doctors are holding. So you just need to have a strategy that you're personally comfortable with and understand the impact of that decision on your illness risk, but then also any subsequent exposure you might have.
I just want to ask Mark, are your scrubs sort of personally monogrammed with, MF or?
I did, in the first lockdown, it did occur to me to have some sort of cheesy, I actually thought about lab coats. I thought that lab coats could be quite fun. But no, we've just got plain black scrubs with a logo on them. Andy, Andrew, if you want to, I'll send you a pair over.
Yeah,
you can be the envy of Olympic Park.
no, I think they're probably not so essential from a spread, but I can see why it's a nice way to work. Can I just share the sort of the masks the masks, the P2 masks, Australian design, New Zealand standard meeting. These are worn. They actually had a sponsorship with at the Olympics, so they don't need to be fit tested, and they comply. This is the therapeutic goods compliance. They're actually, if you read through the details, they actually came in when we had the big bushfire epidemic, and they were for some of the smoke and particulate matter. But they're about $2.50 each. And I think if you want to, they don't need to be fit tested. If you want to tick the box, that's a P2 mask, and they're certainly much more comfortable. If you're following the guidelines and changing them frequently, though, $2.50 mounts up, especially a practice our size.
There's a question from Monique about the cost of a deep clean, which I have no idea, but obviously you found it was 6,000. I suspect also that it's the same as case numbers increase, the requirement to do a deep clean and also the evidence around surface transmission is going to probably mean that it's not as required, but that whole thing around ventilation is definitely worth considering. I'm having a hard time
They've changed our rules about the deep clean, and if you on the table like you've got, there's one tick the box if you have appropriate cleaning, which is clean all surfaces once a day with hospital grade sort of cleaning material.
Cool. And just there's one, Dan, do you know if you got any update about rapid antigen testing and availability for testing in New Zealand? You got anything to add there?
No, it doesn't appear to be coming at a rate of knots.
No,
unlike the US, where you can buy it at the pharmacy. So don't hold your breath would be my thoughts.
So there's a school, a private school here that does it on every student and staff member every day, which is quite astonishing. Shows you how much where your money goes in when you go to private schools.
Cool. Well, look, thanks for joining us, Joey. It's been good to see you. It's been good to see you with that haircut as well, actually. And yeah, look, we really appreciate it, and thanks.
At least I've got some.
Yeah, well, that's true. It's an easy win, that one, isn't it? Easy win.
easy win.
So I've got a lot more hair than I had a few weeks ago. It's been interesting to see where it grows back and where it doesn't. But anyway, it's not anyway. Move on quickly from that. So yeah, thanks for those of you out there coming and listening. It's an interesting time for you, and I hope you're all going well, easing back into your practicing lives. We're probably going to hit a bit of a pause, I think, on these webinars for a little while, just given I think people are going to have more interesting things to do, but we might look to kind of keep them going at a slightly less frequent level, maybe once a month or something similar. So if you do have any ideas or feedback about how we can make these better, or whether you'd like us to keep going, make sure you either flick us a message or post them to Facebook. I'll put those 3 documents up there with the video of the webinar tomorrow. But otherwise, enjoy your long weekend. I hope you get away and enjoy something exciting, possibly down to the Coromandel. Yeah, hilarious gags. So thanks a lot, Andrew. Look forward to seeing you sometime soon.
Good to see you guys. Thanks for having me. So hi to all my friends over there. I saw a message from Chris Hanna. Hi, Chris. And yeah, good luck. Hopefully, on the other side of this, you get out of it better than we will.
Yeah, well, good luck. I mean, it must be a little bit unsettling with the change overnight. So travel safe. And
got a booking at the pub tomorrow, though.
Oh, do you? to watch the horses, or?
Horses, of course.
All right. Well,
All right.
we'll catch up with you a bit later on.
See you. Bye.
See you. Bye.
Cheers, Joey.
Bye.
Bye.